So I'm Erin Ward. I'm a parent of a 17-year-old with complex medical needs, and he had a surgery, spinal surgery, 3 years ago now, and I was really excited to be a parent partner for the Complex Spine Project.
I'm Jay Berry. I'm a general pediatrician and a hospitalist with a major interest in coordinating care for children with medical complexity, and I've been working closely with the surgeons to help prepare their patients for spinal surgery.
I'm John Emmons. I'm a pediatric orthopedic surgeon concentrating in spine for the last 3 decades. And I've had the privilege to take care of many involved patients with severe spinal deformities. And I look forward to trying to share my perspective on this. I think I also have a little bit extra edge on this because I had a child who had many surgeries. So it gives me a little bit of the parent perspective.
So Dr. Berry works in a lot of different projects with complex care, and that's a great interest for me. So after Will's spinal surgery, he approached me about being part of this project, and we had the great privilege of having Dr. Emmons be Will's spinal surgeon. And so we were excited that we could bring him into the project as well.
Well, I think solidifying us three together, we applied for this federal grant to try to re-engineer a bit of perioperative care for complex patients. And children with neuromuscular scoliosis undergoing spine surgery sort of bubbled to the top as a priority patient population to work on. I think that's how I got connected with Dr. Emmons and working clinically with his patients. And then from our prior collaborations with Erin, we love her so much that we said, Erin, you've got to be our patient and family engagement spokesperson for this process, especially since you guys have experience of surgery, the spinal surgery with Dr. Emmons, and going through that.
Yeah, over these last couple of years, we've tried to change the paradigm of how patients approach complex spine surgery. And rather than just depending upon the spine surgeon and other specialists to make decisions and interact with the family, having an overarching, coordinated person, in this case Dr. Berry, I think has made a big difference. So I'm looking forward to the next period of time when we have a more coordinated approach to deciding about surgery. The involved patients, the patients with multiple medical comorbidities and multiple medical diagnoses who come to spine fusion are complex in lots of different ways. Their underlying medical conditions make the parameters for taking care of them very different. Their particular curves are potentially very different. The curves occur in different severities. The curve can have very different effects on their overall functioning. So if you have very stiff hips or very stiff knees or have a great deal of spasticity, then the curve occupies a different place in the overall care of the patient. So both from the curve point of view and from the medical point of view, everybody's different. So there are many different variations on the situation. And the third is age. Depending on the age at which the child comes to the level of potentially needing surgery, different decisions need to be made. So from the surgeon's point of view about just deciding what operation to do and what anesthesia to do and how to get the patient through this, it's very complex. And that says nothing about the complex decision making on the part of the other caregivers and on the part of the parents.
This was probably one of the most complicated and challenging decision-making processes we had for our son, and I think it's because the surgery itself is so complex, like Dr. Emmons said, but then in the context of a child who is so complex and has so many different specialists working with them and having opinions and wanting to weigh in, and then the process of making the decision was very complex, and at the time felt like we were maybe missing a little bit of a roadmap of how to be thinking about this complex process to make a good decision for Will.
Well, the issue is that you have this underlying neurologic disease that's affecting the curvature of the spine. And that neurologic disease is severe enough to do that. Usually it means that it's affecting the other organ systems of the children's bodies, right? Because your nervous system innervates everything. So a lot of these children end up having additional comorbid conditions which affect their health, their ability to digest food, to urinate, to stool effectively. They have bone problems, they have endocrine problems, cardiovascular, respiratory problems. And all of those issues come into play when thinking about how healthy a child needs to be to undergo the operation, and how all those health issues might affect their recovery. And I think all of that sort of weighs in also on whether we think the surgery should be done or not and how effective it might be. And as Dr. Emmons was saying, I mean, every child is different. Their underlying neurologic condition may be nuanced. Their comorbidity profile is distinct. And so you've got to really approach each child differently to be able to figure out those answers and figure out how to proceed.
It's a little bit like a moonshot in that there are lots of different things going on that are changing, and they all have to be as good as they can be for the rocket to take off. So if you recently had an upper respiratory infection, then that's a bad launch. If you recently lost weight, that's a bad launch. But all of these different things make a difference. So if most of them are okay, then probably things will be okay. But if all of them are okay or as good as they can be, then the chance of getting through the surgery without a problem increases.
I think that would be the parent's dream, to be assured that everything's going to be just fine and it's going to be successful. But I think at the age of when Will went through it at 13, we had been through enough things to know that his life of medical complexity is quite uncertain. So I think as a family, we were probably a little bit more comfortable with that idea of uncertainty. And honestly, we had probably the best experience when Dr. Emmons kind of expressed how uncertain things can happen and the outcome is not always certain. So for us, it was actually finding a match and a shared experience of understanding that this is very complex, recognizing that, being real about uncertainties, but then also looking for some assurances of the likelihood that things might go well, and what we could do to make sure that we have the best chance of it going well.
From a physician point of view, we would like everything to be cut and dried, and we'd like the outcomes to be predictable and to be certain. That's clearly not the case. We're often surprised at things that either go well or go badly, and to try to share your uncertainty with the family puts us in an odd position. So some families kind of feel as if you don't know what you're doing. If you say, well, I'm not sure how this is going to work out, I'm not quite sure what the right choice is here. But I think in the end, just being as absolutely honest as possible about what you're worried about and what you really think may go right or may go wrong is better. So sharing with the family that the bone may be too soft to achieve satisfactory fixation and that you may not get very much correction, or that the rods may pull out of place or something like that, that's worth bringing up, as opposed to saying, oh, don't worry, I'll worry about that, everything will be fine. So I think that transparency helps, and multiple conversations help.
Mm-hmm.
And we just have such little evidence overall. There's such little scientific background studies that we can pull from that tell us, based on this child's comorbidity profile, their age, their degree of curve, everything else, their likelihood of having a smooth post-op recovery is this, and the likelihood that the surgery is going to work is this. And so it really is so much left up to clinical judgment of us subjectively trying to put all this information together to convey what we think is the most accurate portrayal of risk and benefit. But even when we do that, we're caveating it with so much uncertainty around that, which is not reassuring.
So in terms of making the decision and thinking about all the different aspects and how it would influence Will's life if we did it or not, we definitely spent time trying to weigh both options. And actually, Dr. Emmons was very helpful in that. Some of the concerns we had were specific around his diagnosis, which he has a neuromuscular condition that the children often have very soft bones. And that was something, we knew as a physician he understood, but we also we needed that level of assurance to know in the context of his disease that was brought to a different level. And what was most helpful was when he was able to pull up a past patient, anonymously, records and be able to look at the bone density scales and be able to say, I have performed surgery on someone with this level of bone density issues. So it was like one concern, but then also raising it to a different level that this is, really something we need to take into consideration for my son. In terms of quality of life issues, that was something that was really important for us to meet several times to be able to convey to a surgeon that we didn't have an established relationship with the uniqueness of our situation, how Will lives his life, how past surgeries have been successful for him, how he's overcome odds. And our decision was really driven by cues we've gotten from him and how happy he is when he's able to sit up in his chair and be comfortable and to go to school and spend the full day at school. And when those things were starting to be compromised because of his spine getting so bad, that was one of the main reasons why we decided to really pursue trying to make this decision to move forward.
This pre-op period is so much about discovery and trying to discover where the child's health is currently and what you project it to be. And you have to go to multiple sources, I think, to figure out how to get to that point to understand that fully. And the parents, family members, the children themselves are going to have issues that they're concerned about. The surgeons are going to have things that they're concerned about, or whatever. Anesthesia is going to be involved. They're going to have their own thing. The children's specialists may have their own thing. You may have an aunt or an uncle that raises their hand and say, "Oh, I've always been worried about this." So, like the hopes and concerns, I think you've got to really do your due diligence about trying to talk with everyone to bring it all together. And as Aaron said, it's so hard to do that in one outpatient clinic office visit. If you consider sort of the typical health system of, okay, we're going to bring a kiddo in who's going to, is under consideration for surgery, and we want to talk about this specifically for 30 minutes. The children are so complicated, and their past medical history is so deep, a lot of them, that you just can't do it. You have to think about a recurrent system, I think, of learning a little bit, calling the families, talking with everyone. There may be multiple email communications and phone calls and recurrent office visits that over time brings it all together, and suddenly you've got the picture kind of painted on canvas of what this is going to look like and how you're going to proceed with it.
I think it's almost impossible for a parent to absorb all of the indications for surgery, all of the potential complications, all of the factors in one visit or even a couple visits, no matter how educated they are. So parents with a medical background still have difficulty absorbing everything. And to the extent to which we as providers can give them multiple sources of information, it's useful. One of the things I try to do is try to explain as much as I can to the family, but then I sit down and write them a letter that says the same thing all over again, because I know that it's impossible to absorb all that. And then with something in writing, you can read that and sort of say, "Oh, wait a minute, we didn't really talk about that. I don't understand what that's going on." So the next time, I can go over that again. And I think most of us try very hard to not push for a decision, if you will, in the beginning, but try to make make it educational, and then gradually approach the decision.
And I would echo Dr. Edmonds' comments. I feel exactly the same way as a general pediatrician trying to wrap my head around everything to consider for one kid. So, getting input from the surgeons and anesthesia and all the specialists and the parents and everyone else sort of puts it together to help me think through it. And very rarely, if I put my brain on a case, do I pick up everything that's there that we need to consider and optimize. So it's a lot.
And I feel there's some ways the structure of how the system is set up can be really challenging. You have an initial consult and maybe a second consult, and you decide, you think you're moving forward, and surgeries need to be scheduled so far out that you put a date on the calendar. But we were continuing to go through the decision-making process up until the moment we said, have a good surgery well. It was an ongoing thought process and rethinking it and weighing the options, even though that date had been set several months ago.
Yeah, there's some circumstances in which the physicians or the system decides that surgery just is not the right option, not just at that time, but kind of ever. And there are some situations also in which the family decides that it's just not a good idea. I think it's important as a surgeon to say to the family, if you decide that you don't want to do this surgery, even though I may think it's an appropriate thing to do, I will stick with you and support you in this decision and not abandon you. Because I think many families feel that if they decline the physician recommendation, that they are then outed from the system. I think it's important to be supportive for them. One of the traps in deciding to not do surgery is that over time, surgery becomes more difficult in many circumstances. So usually surgery is proposed when it is clear that a neuromuscular scoliosis is going to be a problem. It's much medically much more there's much more not just satisfactory, but it's much more successful to do the surgery on a moderate deformity rather than let the full-blown natural history of the deformity become obvious. So if you say at age 13 that yes, it looks like a bad curve, but it's just not bothering them that much, I don't want to do anything, let's wait and see what happens. And then if you come back at age 22 and there is skin breakdown from the curvature, the child has much more severe respiratory issues, nutrition has become more of an issue, there are recurrent pneumonias, that becomes a procedure that is very difficult to undertake. So it's also worth emphasizing that it's fine to say no, and I will support you in the no, but you are making an active decision by choosing to not do a spine fusion.
And we've definitely had a number of cases over the years where we felt like the fragility of the child's health at the time of undergoing surgery was too great to keep them safe for the operation. That the stress of the operation, anesthesia and everything else, there was, in our subjective opinion, a high likelihood that the outcome afterwards would not be favorable. And that's a really tricky point to try to reach in terms of risk benefit, but we've definitely gotten there with a lot of families. And again, often that doesn't happen in one conversation, but it's this recurrent discovery, new information sort of rolls in as we're working up different aspects of organ system functioning and things that helps us reach that decision. But as Dr. Edmonds said, it's a difficult one to make because if the scoliosis curve itself is progressing and getting worse over time, you may have this window where you feel like this is the most opportune time to operate. But if the child's health and fragility is not stable enough to meet that window, then maybe it's best not to pursue it.
The other major reason to not operate on bad scoliosis curves or bad spine deformity is the presence of very stiff hips or very stiff knees. So many children with spasticity, either because of the spasticity or because the spasticity and operations or hip dislocations, end up with hips that do not move very well. And they need their spine movement to be able to be positioned. And if in a well-meaning attempt to align the spine, you take away the spine motion, and of course that's a fundamental part of spinal fusion, is to stabilize and stiffen the spine. If you take away the spine movement and the hips and legs are already stiff, then positioning and transfer and so forth all become much more difficult for the patient. So for some patients, it's best to leave the spine deformity and take advantage of the spine motion. That's probably, I think, the biggest reason that I see for not doing a procedure in someone who's otherwise medically stable.
I would say I really appreciate what Dr. Emmons says about when a family makes a decision not to move forward, sticking by that family and being able to support them and provide whatever supports are going to help that individual be comfortable and maximize their quality of life with the severe scoliosis. I've had friends who've made the decision not to have surgery, and thankfully they've had people around them that have tied them into palliative care, when necessary hospice care. And actually we requested palliative care to be integrated into our plan of going through the surgery. I'm a big supporter of palliative care, but because Will's not inpatient often, we just never had those conversations happen. And we thought that regardless of what decision or outcome we make, we want that in place to be able to provide wraparound support for us. I would say being able to have a surgeon and a team walk you through what it may look like if you don't have the surgery was really helpful for us. And we were actually, I feel we started thinking about surgery about 8 months to a year before we actually had it. And we were, I think, getting close, if not at that window of it becoming a problem if we waited much longer. And I just remember us having a conversation that fully supportive of whether we do it or not, but also sharing that window was closing where it would become much more complicated and a much more stressful surgery for Will if we waited.
Yeah, phrasing it as a window of opportunity, I think that's probably the right way to do it. It's a window of best opportunity. And if it's much too early, it's not obvious that you need to do something, and it's after that window, it just gets much, much harder and less satisfactory. We, in talking about how to start the conversation about where we're going and why are we even considering doing this, it's worth standing back and talking about where are we going if we don't do anything, and what the physician's expectations are for what's going to happen in the future, either with future growth or just with adulthood with the deformity. And unfortunately, most of the neuromuscular deformities or most of the complex deformities, once they reach a certain magnitude, continue to get worse as an adult. So even though there's no longer growth involved. So we try to explain what we perceive of as the problem for that particular patient with the passage of time, and then try to share that with the family and make sure that they at least understand what we're saying. They may not believe what we're saying because they haven't experienced it, but at least we can explain that. And then try to be honest about what our physician expectations are for function after the surgery. Most surgeries and other things are done for a problem. So if you have appendicitis, then we take out your appendix and you are corrected. Or you have a broken leg and we fix your broken leg and then you're corrected. And the spinal fusion in the complex patient is not really correction. It's a stabilization of a less than perfect situation. So it's worth emphasizing that we're trying to stabilize the spine so it won't continue to collapse and be trouble over time. We're trying to improve sitting position, but we're not correcting the underlying problem. And often that brings out parents' expectations being very different than what we had imagined. So, for instance, some parents often think that their child's ability to transfer independently will be much better after spine fusion, and often it's no better and maybe a little bit worse because of the stiffness, or the child will be easier to handle and easier for the parents to move around in position. And often that's not true either, because the child doesn't fold up the way they did before there was a fusion. So getting all those expectations on both sides of the equation, on the parents' side and on the physician's side, I think is worth talking about early on.
Right. I think it's so important. It's fantastic. To try to articulate what the true reasons are and the expectations for the surgery, as Dr. Emmons was saying. Is this purely cosmetic? From a parent's side, I want my child to look straight. Is it pain? Is it positioning? Is it breathing? Sort of, what is it? Or a combination of all those things that sort of leads to what you think is going to change after the surgery occurs, hopefully. And then trying to be very honest and straightforward about what we think the surgery actually is going to do to whatever symptoms are there that we want to try to alleviate. And then from the general pediatric standpoint of, even if we alleviate some of those things, what is that going to do to the child's overall quality of life and health trajectory? As Dr. Emmons was saying, I mean, this is, to get into the situation of where you're considering this, most of the time it's not something where the spinal fusion surgery is going to just correct everything, and everything is going to be perfect afterwards. So, you're really trying to be thoughtful about what that health trajectory is going to be afterwards, and is it worth it or not?
Mm-hmm. Absolutely. I would say that, ideally every family would love their child to no longer have scoliosis and no longer be in pain and discomfort. And I think what was really helpful was hearing what surgeons thought would be the outcome for my son, and then being able to then think about, does that align, does that meet up with my hopes and concerns and dreams of what he would look like afterwards. I was actually really relieved when we actually had several different consults, and it was, for us, it was really finding someone that seemed to appreciate and understand what we were hoping to get out of the surgery, which was to stabilize and to relieve some and provide some comfort. We didn't really have the expectation that there would be significant correction. We just wanted him to be able to sit up better and be more comfortable. And I felt actually a sense of relief when we found a surgeon that was able to express that. When Dr. Emmons was able to say, we're going to do the best to stabilize, provide some correction if possible, but the goal is to make sure it's not getting any worse. So with Will having a neuromuscular condition, we anticipated that things would continue to progressively get worse. And it was interesting, he had a curve that wasn't necessarily compromising his breathing and his lung capacity. I think for many families, that's one thing that they look to, is if their child's having difficulty breathing. That wasn't really an issue for Will, but then he started getting more uncomfortable in his chair. We noticed that it was having an impact on kind of his hip position. And then he also, the driving factor was when his spine was over as far as it was and was causing skin integrity, and we were starting to have wound issues. And that was pretty scary, and that's when we said, this is time. So those were some of the factors for us.
I think the spine was trying to poke out through the skin, and came pretty close at one point. So yes, I think that was this needs to be done indication. But that's a very obvious indicator, and I think it was very obvious to Will's family that something needed to be done, because here's a problem. There is a definite problem that we have to try to address now. That's often not the case. Often the spine deformity or the scoliosis is an oh by the way problem, and there are lots of other things going on. The seizures are causing lots of trouble, or nutrition's causing trouble, or there's too much reflux, or there are recurrent pneumonias, or there are other things that are much more on the radar than the spine deformity, which is continuing to worsen. So, in this case, there was a clear incentive to do something. In lots of cases, it's more us, the system, the providers, that say this needs to be addressed, and then it's a difficult or a different conversation, trying to bring the family along with what we perceive to be future problems, because we are really proposing a prophylactic operation as opposed to an operation that helps the immediate problem. But what often happens in that situation in the complex child is that you have multiple things going on. So you have the orthopedic surgeon over here saying, gee, we need to do spine surgery. But you've also got the ophthalmologist saying, the strabismus is getting worse and we need to do a little eye surgery. And the gastroenterologist saying, the reflux is worse and we need to change from a G tube to a GJ tube. And the neurologist saying, well, I'd like to try a different dose of Depakote. And you can imagine all of these things all happening all at once. And without an overarching coordinator or supervisor, the issue that tends to win out is often the strongest and best personality. So if your ophthalmologist is a really great person and convinces you that this is really important, then all the energy goes into fixing the strabismus, and all these other things go by the by. So for complex kids, it's important to maintain a sense of perspective. Many parents are very good at that, and we'd like to not necessarily depend on the parents to do it. We'd like to have somebody like Jay oversee this and say, this is important at this time, this can wait, because the individual specialists can't really do that.
And you had.
I would say it'd be wonderful, and we actually are very lucky that we have wonderful doctors that really have guided us through this process. For families that may not have that, I would say that it's one of those things where I think a lot of us that live with complex children, that we kind of just own that already, but it does feel really good to have a shared experience with a medical professional that's willing to really walk through the process with you.
We definitely have cases of the children expressing themselves, especially those who have the function in order to do that. And oftentimes I find that extremely helpful. If you have a adolescent in front of you who says, I'm really having trouble sitting up in my power chair to play my soccer games. And I'm not scoring as many goals as I used to, and this is the thing that I love to do the most, but my positioning is just painful and I can't get through the games. And the parents behind him nodding their heads saying, yes, this is one major thing, we see this getting worse. It's very compelling. I think it changes the dynamic a bit about how you approach the decision making when you have children that can articulate sort of what's happened to them in their bodies as they're feeling the scoliosis and they're experiencing it.
Yeah, I've encountered several young adults who are trying to live alone with personal care assistants or other other adaptive situations, and they're often very, very helpful in determining what part of their particular deformity bothers them and the way in which it bothers them in terms of self-care, or one of the biggest complaints is sort of interaction with others, being able to sit at the same eye height as other individuals, or just feeling like not everybody who looks at them immediately sees their curve and sees that they're out of balance, but instead sees them as an individual with whom they can make face-to-face contact. But it's very revealing to see what their opinion of their spine deformity is and what they'd like to make better. And sometimes we can make that better, and sometimes we can't. But involving the articulate patient is a must when the patient can be involved.
And for our family, Will was very much part of the decision-making process. He was I think a lot depends for families on the age, developmental abilities. Will is a nonverbal communicator, but he has a system of communicating, and he cognitively understands everything he experiences. So it was really important for us to have some kind of really big conversations with him at the age of 13 and help him understand how it would impact his school year, that he would miss school, that the recovery time may be a while, and it was important for him to be part of that process. Most of the, I would say all of the medical decisions we've made, we've taken our cues from him, and he's a fighter, and he thrives, and he's up for the challenge. I remember thinking about recovery, and we thought, okay, our goal would be hopefully to get out of the hospital in 2 weeks. And we were out of there in 7 days, and that was totally driven by Will being, yes, let's sit up in my chair for many hours the day after surgery. I remember Dr. Emmons teasing us that we might have been skewing some insurance data because we were out of there in 7 days, but there was a long recovery process after that as well at home. But
he was able to participate in the decision, and that's good. But I think it brings up another conundrum, which is that if you have a child who is of a very young age developmentally, or just chronologically very young, there's some point at which the families have trouble deciding whether to tell the child what they're about to go through. So in the ideal situation, you can explain to the child what's coming up and all the things that are going to happen, and the anticipatory part of that is all useful. At some other age or stage of development, telling them that this is all going to happen just causes them to freak out. It would be interesting to know from families whether they thought that they made the right decision in terms of trying to tell their child and work through with their child what was going to happen, or whether they wished that they'd just sprung it on them as a surprise. But have you had any discussions with families to that effect?
Yeah, I do know families that often will not tell their child ahead of time if they're going to be going into the hospital, just because there is so much past anxiety around the hospital experience. And I think that's what the richness that families bring to the table is knowing the past experiences of their child and what went well and what didn't go well, and trying to customize their approach based on knowing their child and their levels of coping and understanding.
I think one thing that can be very difficult in this, for the kids that can articulate their thoughts and perceptions and feelings about it, is seeing their disappointment sometimes when the surgeries have to be delayed or moved out. You know, as we talked about, there's so many active health issues that children with medical complexity have on an ongoing basis. And finding a window of time when nothing else is active and they're just hanging out ready for surgery in a very calm health state can be pretty rare.
And having the hospital have the availability necessarily to take
to accommodate
them on.
them. That's exactly right. So pneumonia, 2 weeks before surgery, worsening seizures, major GI dysmotility and reflux or constipation. The list just goes on and on. If any of that stuff sort of happens, neurosurgery and you consider, well, in the context of that, it's better to delay and you push it off, and then that can be really difficult because they're prepared for it, they're ready to go, and then, sorry, you have to wait. It can be difficult.
And it also, honestly, having been in that type of situation before and having friends that have, it starts you wondering, are we making the right decision? Is this, anyone that, has, depending on different people's faith and how they move through life, if sometimes they see things as signs, like, was this just not meant to be? So it's interesting.
I think there's a not so low likelihood that you're going to run into situations where the decision to perform the surgery or not, on either side, there's reservation. It's not a 100% comforting decision either way. And you may not have the full healthcare team or family members or everyone fully on board or not on board. And how to wrestle with that and cope with it and move forward, I think, can be very challenging. But I think it's important for families to know that.
Oh, absolutely. I think one of the first things I thought about when we were thinking about this project was no one wants to have to make these decisions. It definitely felt at times that neither option was an option that I wanted to have to consider or think about. I think one thing I would have liked to think more about and to know more about is more the long-term possible side effects. Even more specifically, just for my son's condition, there are some indications that potentially could come up, and also some of them that could potentially be related to a major surgery. For example, a few months after surgery, he wound up having gallstones, and then a few months later, he had kidney stones, and those are things that potentially he might have already been developing with his diagnosis. But there is also some thought that potentially major surgery might have also escalated some of those issues for him. So I think projecting a little bit further out some of the longer term issues, I don't think that necessarily would have changed our decision or the pathway that we took, but just being more prepared to pay attention for those things. Something I would want other families to know. I think I would just want to share with other families to encourage them to be kind to themselves when they're going through this process. It can be such an incredibly heavy decision that you feel you're making for your child or with your child. And you can lose sleep out over it. You can continue to kind of bounce back and forth between decisions, and find the people that are your allies in the process. Having an incredible surgeon, having the other go-to doctors you have on your team that you really value their opinions, and try to work together through different challenges that may come up along the way.